each part, you will hear a number of different extracts. At the beginning of the test, you will hear a beep sound. You will have time to read the questions before you hear the extracts. You will hear each extract once only. You have to complete your answers as you listen. At the end of each test, you will be given 2 minutes to check your answers. Part A. In this part of the test, you will hear 2 different extracts. In each extract, a healthcare professional is talking to his patient. For questions 1 to 24, complete the notes with the information you hear. Now, look at the notes for extract 1. Extract 1. Questions 1 to 12. You hear a physician talking to a new patient, called Mrs. Delilah. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor.
Yes, Miss Alyssa, what's your problem?
I'm getting acne from continually washing the area around my chin, right temple, and left temple, and the condition is still worsening.
What's your age?
19.
How old were you when you started your period?
Well, it was when I was 13.
And can you describe the length of your cycle?
Once in 24 days, and it lasts for almost 6 days.
Would you describe the flow as light or thick?
It's light.
Do you use any medication?
Yeah, I take the oral contraceptive pill.
Are you allergic to any drugs?
Yes, allergic to penicillin. I feel difficulty in breathing.
What are the medicines you are taking?
Alisi 28, 20 mcg, 0.10 milligram tablet.
Is anyone in your family prone to any disease?
Yeah, my mom has stress disorder and anxiety.
Do you smoke or drink?
I don't smoke, but I drink socially.
You drink caffeine?
Yeah, 4 servings a day.
Your diagnosis report shows you have symptoms of periodic reddening of face, acne problems, and allergies. And a diagnosis of epicrine and apocrine glands shows no evidence of hyperhidrosis, chromhidrosis, or bromhidrosis. But your face shows keratotic papule. I would suggest you go for antibiotic therapy. Take a tetracycline, 250 milligram capsule. I would also suggest you take an oral antibiotic therapy with doxycycline, 100 milligrams a day.
Doctor, why does the acne occur?
Acne is a skin condition that happens when your hair follicles become clogged with oil and dead skin cells. It often results in blackheads or pimples, whiteheads, and often appears on the face, chest, forehead, chin, shoulders, and upper back and shoulders. Acne is most common among teenagers, like you. The androgen hormones increase during puberty, causing the sebaceous glands to enlarge and secrete more sebum. Hormonal changes during pregnancy and the use of oral contraceptives also impact sebum secretion. Moreover, low amounts of androgens circulate in the blood can still worsen acne. Medications such as drugs containing corticosteroids, testosterone, or lithium worsens the disease.
Which food should I avoid, doctor?
Certain dietary factors, such as skim milk and carbohydrate-rich foods such as bagels, bread, and potato chips, worsen acne.
Can you recommend any effective foods for acne?
You must stop eating processed sugar, caffeine, dairy products, and processed foods. And you should include foods that are rich of antioxidants, anti-inflammatory compounds, and other acne-fighting nutrients. Foods such as blueberries, sweet potatoes, green tea, carrots, cilantro, spearmint, oats, apples, barley, and mustard greens.
Okay. Thank you, doctor.
Thank you.
Extract 2. Questions 13 to 24. You hear a physician talking to a patient. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning. I've got an appointment with Dr. Gonzalez at 8:30.
Okay. Please be seated. Let me check with your record. In the meantime, please sign in and be seated. Margaret Nicholson?
I'm here.
Follow me to room number 3, please. Here we are. What's the reason for your visit today?
Well, lately, I've been feeling really tired, and often I get frequent headaches and an upset stomach. Moreover, I've been getting a persistent cough for like the last 3 weeks.
When did these symptoms start?
I started feeling tired all the time about 2 months ago. Then, a few days after that, the headaches started. I got the upset stomach long before feeling the tiredness.
Are you taking any medications?
Only vitamins.
What vitamins are you taking?
I am taking vitamin C, and a multivitamin tablet daily.
Okay. Let me examine your vital signs.
How am I doing?
Everything is normal. No high temperature, and your blood pressure is also normal. Please wait for a moment here.
Thank you, doctor.
I see here that you have started feeling tiredness 2 months ago, and then frequent headaches. You're also suffering with an upset stomach and a persistent cough. Did you run a fever as well?
No, doctor.
Let me perform a quick physical checkup. Take a deep breath, hold your breath for a moment, and exhale. Repeat this again. Have there been any changes in your diet or your weight recently?
My diet is the same, as usual. However, I lost 5 pounds very recently.
Did you ever suffer from insomnia?
Well, it is pretty hard for me to fall asleep. I also wake up often during the night.
Do you drink or smoke?
No, doctor. Well, recently, the ownership has changed, and I had to work a lot of overtime at late hours, even during the weekends.
I think you are suffering from pneumonia. Other than that, I do not see any other problem. The reason could be probably the stress at your workplace that causes headaches, upset stomach, and sleeplessness. For now, try to relax yourself and start doing exercises. Meet me again after you receive all the medical diagnosis reports. I'm going to prescribe medicines for bacterial pneumonia. Are you allergic to any medicine?
Not to my knowledge.
I want you to do a blood test and urine test to identify the bacteria Streptococcus pneumoniae and Legionella pneumophila.
Is it something serious, doctor?
Not at all. I doubt that could be bacterial pneumonia. Take levofloxacin, 750 milligrams orally, every 24 hours for 7 to 14 days.
I want to know my cholesterol level. When will I get the medical reports, doctor?
You will get the medical results in 2 weeks. Don't stress yourself. Everything will be okay.
Can pneumonia be prevented, doctor?
In most of the cases, pneumonia can be prevented. You can have a vaccine to defend against pneumonia once you get all these medical investigation reports. I would suggest Prevnar 13 pneumonia vaccine. That is very effective against 13 types of bacterial pneumonia.
What food should I include in my diet, doctor?
Have plenty of fruit juice and fresh fruits, yogurts, milkshakes, smoothies. Eat plenty of full cream milk or yogurt, or even ice cream, with light meals of lean meat, fish or eggs, and cooked vegetables.
Thank you, doctor.
You are welcome.
In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a nurse briefing a colleague at the end of her shift. Now read the question.
Okay, so the next thing is about Susie Williams in bed 3.
Right.
She's been admitted for chest pain to rule out MI. So far she had an EKG, which was okay, and the first set of cardiac enzymes and troponins are negative. When she came in, her blood pressure was elevated a little, like 182/95, but she was given losartan, and at 6 o'clock it was 142/82. She was also dehydrated, so we started her on IV fluids. D5, half normal saline, running at 125 millilitres. That can go until midnight and then it can be disconnected. She's scheduled for a stress test tomorrow and some more enzyme tests. Okay?
Okay. Question 26. You hear part of a hospital management meeting where a concern is being discussed. Now read the question.
Now I'll hand over to Jenny, who has a few words to say about staffing. Jenny?
Thanks. Now, if we compare ourselves to other hospitals of the same size in other regions, we're actually recording lower rates of staff turnover. That's just as well, given the challenges filling vacant positions across the sector. Where we do compare unfavorably is in the number of days lost to sick leave. That's making it hard to maintain full cover on the wards, and we all know the costs of that. As a matter of urgency, then, HR are looking into the worst affected areas to understand the reasons behind it and to see if there's anything we can do to help and support the staff involved.
Question 27. You hear a GP and his practice nurse discussing a vaccination program. Now read the question.
It's coming up to that time of year when we have to start preparing for the flu vaccination programme.
Yes, we usually do it at the start of next month, don't we?
That's right. If you remember last year, we hired a local hall and did as many people as we could in one afternoon.
Yes, I just started working here then. It was a hectic couple of hours, but it worked pretty well, don't you think?
Sure, but there's been so much publicity recently about how sensible it is to get the jab that I suspect we'll have a lot more people coming along this year.
So it'd be better think about taking on an agency nurse, perhaps, to lend an extra hand.
OK, let's run that by the practice manager. And she might have some other suggestions too.
Question 28. You hear 2 hospital nurses discussing the assessment of a patient on their ward. Now read the question.
bed manager just rang. He wants us to clear 3 spaces in the ward today.
Oh, it's never ending. Let's see what we can do. There's no one ready to be discharged, but we could try chasing referrals for Mr. Davison to the community hospital for rehab. Where are his notes?
Yes, but has he had his assessment yet?
They were all away at that conference yesterday and the day before. I think he'll have slipped through the net.
But Dr. Amat's already got him medically stable and signed off, so he should be the next one to move on.
Well, I'd get him there as quickly as possible before they give the place to somebody else.
I'll phone them straight away.
Question 29. You hear the beginning of a training session for dental students. Now read the question.
This is session number 4, which is going to include, again, impression taking. We've created the crown impression of tooth number 30. We also took care of an inlay preparation. So today, we're going to stay on that side with our impression taking. We're going to make a duplicate of what we've already done, and our attention to detail is now going up another notch. When I take an impression of a tooth that I've created in the mouth, I naturally have to take care of the saliva, the blood, the gum tissue. We're not going to cover all that today. You'll hit that next semester. What we are going to cover are the dynamics of your impression, the margins, the proximal contacts, the bite, and the occlusion. We're going to capture all that in one impression.
Question 30. You hear 2 nurses discussing the treatment of a patient with a kidney infection. Now read the question.
I can't see the results of Mr. Roberts' last blood test to check creatinine levels. Did you do the last one?
No, not me. Let's see. Ah, here it is. The last test was 4 hours ago and results show a level of 38, so it's still well below normal. We'd better do one when he wakes up, as it might have changed. The patient's not keen on needles, though. I had a real job last night trying to convince him it was necessary. Not the easiest of patients, if you're happy to have a go.
Okay, my turn, I reckon.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear a geriatrician called Dr. Claire Cox giving a presentation on the subject of end-of-life care for people with dementia. You now have 90 seconds to read questions 31 to 36.
My name's Dr. Claire Cox. I'm a geriatrician specialising in palliative care. My topic today is an increasingly important issue: end-of-life care for dementia patients. The care of dementia patients presents certain problems. Dementia is a terminal illness and is the third highest cause of death in Australia. Different from other such conditions, it has an unpredictable trajectory, and there can be difficult issues around patients' mental capacity, decision-making and communication. But, in spite of an equal need for palliative care services, dementia patients don't always fit the traditional model of such care. Families often suffer distress because they feel unable to ensure that their loved one's wishes are being respected, or just don't know what that person wanted because the discussion wasn't held early enough. There is therefore a clear need for well-funded, patient-centred palliative dementia care that's available when and where it's needed. I do a lot of work with Dementia Australia, an organisation which represents the needs of Australians living with all types of dementia and of their families and carers. It also campaigns on dementia issues and funds research. Dementia Australia decided it was the right time to examine the issue of end-of-life dementia care from the perspective of the consumer as well as from that of the healthcare professional. It's a timely initiative. We have plenty of anecdotal evidence but not enough hard facts about what's going wrong and why the system's failing. But the current situation isn't all bad. Despite the issues I've mentioned, I've heard some wonderful examples of how it has made a big difference to people's lives. Things can obviously go badly wrong if this isn't handled well. But in the right circumstances, people with dementia can reach the end of their lives peacefully and with dignity. Dementia Australia commissioned researchers to conduct a survey on the end-of-life issues affecting dementia patients. The survey covered both care professionals, that's doctors, nurses, and others working with dementia patients, as well as family member carers. The interest was overwhelming, with more than 1,000 responses from around Australia. But what do the results tell us? Well, the initial results confirmed what we've heard about access to appropriate end-of-life care. It was obvious immediately that there was a between the perceptions of care professionals and family member carers about end-of-life dementia care. For instance, while 58% of family member carers said that they didn't have access to palliative care specialists and 68% didn't have access to hospices, 3/4 of care professionals indicated that people with dementia in their area do in fact have access to palliative care. This begs the question of whether consumers, that is patients and family member carers, might not be aware of services that are available. Another notable finding of the survey was that care professionals often lack knowledge of the legal issues surrounding end-of-life care. Some reports indicate that care professionals are at times reluctant to use pain medications, such as morphine, because of concerns about hastening a patient's death. However, access to appropriate pain relief is considered to be a fundamental human right, even if death is earlier as a secondary effect of medication. Our survey found that 27% of care professionals were unsure about this, or didn't believe that patients are legally entitled to adequate pain control, if it might hasten death. So perhaps it isn't surprising then that 1/4 of former family member carers felt that pain wasn't This lack of awareness extends beyond pain management. The statistics on refusing treatment were particular. Almost 1/3 of care professionals were unaware that people have the right to refuse food and hydration, and 1 in 10 also thought refusal of antibiotics wasn't an option for patients in end-of-life care. How can we ever achieve consumer empowerment and consumer-directed care if the professionals are so ill-informed? There's a clear need for greater information and training on patients' rights. Yet over 1/3 of care professionals said they hadn't received any such training at all. It's obvious that end-of-life care planning is desirable. Discussing and documenting preferences is clearly the best way of minimising the burden of decision-making on carers and ensuring patients' wishes are respected. Advanced care planning is essentially an insurance policy that helps to protect our patients in case they lose their decision-making capacity. Even though a patient might believe that loved ones will have their best interests at heart, the evidence shows that such people aren't that good at knowing what decisions those they love would make on complex matters such as infection control and hydration. So before I go on,
Now look at Extract 2. Extract 2. Questions 37 to 42. You hear a hospital doctor, called Dr. Keith Gardner, giving a presentation about some research he's done on the subject of staff-patient communication. You now have 90 seconds to read questions 37 to 42.
Good morning. My name is Dr. Keith Gardner, and I'd like to talk to you today about some research I've been involved in concerning something that affects all health professionals: staff-patient communication. Now, firstly, let me reassure you that in feedback, patients seem positive about the way information is communicated to them. But I recently decided to explore the issue in more detail when I was in a hospital with a patient and witnessed for myself what can result when a healthcare professional assumes they've made themselves clear to a patient, when in fact they've been anything but. Luckily, I've had very few complaints made against members of my team, but the potential is certainly there. So first, let's start by looking at a typical hospital admission for an inpatient, and the first communication they have about any procedures they are to undergo. On arrival, a patient will complete necessary paperwork. Various staff will talk to them about their treatment during their stay, which is designed to reduce patient anxiety. However, from some patients' point of view, this interaction can seem very complex and difficult to take in, especially at a time when they're not at their best physically or mentally. So it's doubly important to check that any communication has been understood. Now, to illustrate what I'm talking about, let's take a hypothetical situation. I often use this because it highlights the potential consequences of poor communication. A man in his 80s is admitted to hospital, despite his protestations, with ongoing severe back pain. On investigation, it's found his cancer has spread. The outlook is poor, and further compounded by his becoming depressed and refusing to eat while in hospital. A feeding tube is inserted, a procedure which the patient complies with, but which his family members query. The doctor on duty updates them, assuming they're aware of the severity of the patient's condition, when in fact no such prognosis has been shared with them. An extreme case, but a plausible one, nevertheless. In order to find out exactly what inpatients felt about the service they were receiving in this hospital, we conducted a patient survey. The questions were carefully targeted to capture patients' opinions about the effectiveness of the communication they'd been involved in during their stay. The survey questioned patients on both what they had expected prior to admission and what their stay was really like. These two scores were then used to calculate what's called a gap score. The survey also included questions to measure the patient's behavioral intention, that is, how willing they would be to return to the hospital for treatment. Patients completed the survey themselves, and results were then processed with the help of medical students. Now, the survey produced some interesting data about communication, including both praise and complaints. Clearly, in a hospital situation, staff are dealing with confidential and sensitive information, which must be communicated in private, a situation which can be difficult to achieve in a large and busy hospital. However, we scored highly on that point, and we were also pleased to note that staff did manage to communicate in a manner that treated patients with dignity and respect. Of course, staff also have to ensure patients fully understand what's been said to them. And this last point's where we received the most negative feedback. Both patients and relatives noted a tendency for professionals to resort to the use of jargon and complex terms when explaining both diagnoses and procedures, which left some patients confused. However, patients were generally satisfied with the information about any follow-up treatment provided after discharge. Also, once we'd sifted through all the results, a clear pattern began to emerge regarding the care given by nurses, which I found particularly interesting. I'd assumed that having a number of different nurses attending to a patient during their stay was a good thing, because you need enough staff to cover the various shifts and attend to patients' needs. What I certainly hadn't expected, though, was for patients to say they felt their recovery was faster when they had to communicate with only a small number of nurses. In other words, when they were surrounded by familiar faces. The findings aren't conclusive, and more investigative work needs to be done on a bigger sample, but it's certainly food for thought.